Hello all, my name is Halley Darrach and I'm a PGY3 plastic surgery resident at Stanford. I'll be presenting on a scalable approach to microsurgery education in resource-limited countries. So worldwide, 5 billion people lack access to safe, timely, and affordable surgical care, which is a disparity witnessed most acutely in sub-Saharan Africa. Microsurgery, a fundamental component of reconstructive surgery, unfortunately remains largely non-existent in this region due to lack of access to specialized training and microsurgical instruments. This is important because it is through microsurgery that complex reconstruction, ranging from applications from digital replantation to limb salvage, can be attempted. So without microsurgery, many defects cannot be optimally reconstructed, thus resulting in increased disability and deformity. However, while microsurgery and even basic surgical care remain inaccessible for much of the world's population, one piece of technology has become globally widespread within the past decade, and that is the smartphone. More than 6 billion people worldwide own smartphones today. That's equivalent to 85% of the planet. The use of smartphones as simulators for microsurgery training has been previously reported, but little is known with respect to long-term efficacy and resultant impact on patient care. Our study seeks to objectively gauge microsurgical skills acquisition and progression using a smartphone-based training model over time. For this project, we partnered with Alert Comprehensive Specialized Hospital, a former leprosy hospital in Addis Ababa, Ethiopia, which also houses the largest plastic surgery training program in their country. A cohort of Ethiopian plastic surgery attendings and residents were selected to participate in a 3-day microsurgery training workshop. The workshop consisted of didactic lectures, cadaver dissections, and supervised practice on microsurgical training models, including the smartphone. Prior to and upon completion of the workshop, participants were surveyed for comfort level when performing a microsurgical anastomosis. The smartphone was stabilized at a fixed distance, and participants were recorded performing an anterior wall repair on a 3mm silicone vessel using the smartphone for magnification to simulate a surgical microscope. The video recordings were graded by 4 microsurgeons using the Stanford Smart Scale, a validated instrument for assessing microsurgical skill. With respect to results, pre- and post-workshop survey responses indicate that the Ethiopian attendings and trainees were constrained in their microsurgery training by their resources. Only 2 respondents had their own surgical loops, and none reported access to a microscope. The average number of vessel anastomoses respondents had performed prior to our workshop was 1.8. However, following the 3-day workshop, respondents self-indicated significant improvements in instrument handling, suture loading, and knot tying. Follow our cadaver lab component, which gave participants the chance to perform flapped harvest dissection of the latissimus, radial forearm, rectus, and fibula flap. All participants indicated increased comfort with flap harvesting. As you can see, most participants only had experience with the pedicled latissimus prior to our workshop. Most importantly, overall microsurgical performance SMART scores improved upon completion of the workshop, which were statistically significant in a majority of domains. Our findings suggest that smartphones can serve as valuable tools for practical microsurgical skills acquisition in low-resource settings. The portability, affordability, and versatility of smartphone tech make it an attractive solution to address the challenges associated with accessing traditional microsurgery training resources. Further research is required to evaluate the long-term impact of smartphone-based training, but even in the short term, participants were able to demonstrate significant improvement. We are currently assessing this cohort at 6 months post-workshop. The package we propose to expand our model consists of a tabletop microscope, a mobile phone adapter for personal practice, and a microsurgery primer for self-directed learning. We also plan to launch the second iteration of this workshop in Zimbabwe this coming December at the 2024 COSEXA examinations.